Good morning, everyone. Good morning. I think we'll go ahead and get started. I'm so pleased to be here introducing my friend and research collaborator, Dr. Michael Ackerman. Michael went to college at Luther College and from there to medical school at Mayo Clinic, where he has been ever since. He's currently a professor of medicine, pediatrics, and pharmacology at Mayo Clinic College of Medicine and Science. He's also the Windland Smith-Rice Cardiovascular Genomics Research Professor and the director of the Long QT and Genetic Heart Rhythm Clinic, and as well as the Mayo Clinic Windland Smith-Rice Sudden Death Genomics Laboratory. Additionally, he's the president of the Sudden Arrhythmic Death Syndromes Foundation, or SADS. Mike's multiply grant-funded research discoveries from the bench to the bedside, as described in over 550 original publications, have vastly expanded our understanding of the genetic basis of many cardiovascular diseases, as well as their treatments. The importance of his work is very widely recognized, including last year's winning the Heart Rhythm Society Distinguished Scientist Award, which recognizes a lifetime of achievement, and I think Mike's probably several decades younger than the average winner of that award for his accomplishments. So I'm so proud to introduce Mike and look forward to his talk.
Thanks, Rachel, and good morning. I'm really excited to be here. I've been looking forward to this 2 days for quite some time and have a lot of special friends. Rachel, in particular, and our collaboration these several years has been really rich and rewarding. And to see Dr. Hillebrand, and he probably doesn't know the impact he actually had on my life many years ago with a comment that he made of encouragement. So you just never know what seeds you plant and when you plant them, so thanks. And I'm looking forward to this morning and our schedule today, and new friends. Cheyenne's my best new friend in Peds EP, and so looking forward to the cases. I love hearing about the cases from the trainees, so our time this afternoon, I'm really looking forward to it. I hope you've been looking forward to this topic. I love it, and I hope to give you what is the state of genetic testing in our world of sudden death predisposing genetic heart diseases, otherwise known as the cardiomyopathies and the channelopathies. I'm conflicted. These are those RWIs. I don't think they'll adversely affect our ability to do this well together, but you can be judge and jury of that, because what I think we need to do well together is to recognize what are the various phases, the phenotypes of the cardiomyopathies, and I'll use mostly HCM, and of the channelopathies, and I'll use mostly long QT. We'll then assess what are the currently available genetic tests. There will be no mention of genetic test companies unless you ask. And I'll make sure that you and I know how to evaluate their yield and their role, and that is going to be critical. And then finally, we'll spend the most time, or about a third of our time actually, on some basic foundational principles on how to interpret the genetic test. Because here, the genetic test interpretation, I can tell you, we are fumbling the ball tremendously. There are tremendous, shall we say, in light of the game last night, turnovers taking place. And we need to know how to really bring genetic testing into our practice as probabilistic tests. It's really hard to believe, isn't it, that the discipline of genomic medicine is now 18 years old, when the private and the public completion of the Human Genome Project was achieved. And really, we're now celebrating this month the 16th anniversary of this voyage at the price of $1 a nucleotide, for which it was declared one of the greatest feats of exploration in history, an inward voyage of discovery. And as we'll see, that same year, I and others warned that it also might be an outward journey into chaos and confusion. Very few people heard about the chaos and confusion part. It was all the rah-rah, the Human Genome Project is going to make us enlightened, and we'll be genomic-minded physicians, and it will help us to precisely take care of our patients. We've all heard these buzzwords, haven't we, of precision medicine and individualized medicine. And so we're going to unpack the inward voyage and the chaos and confusion at the same time. And certainly it has done both in our field, where now literally thousands of genetic tests have been brought into medicine, and they've made our way to our world of sudden death predisposing genetic heart disease. And we've had some guidance now for 8 years in terms of how do we, the community of cardiologists, use genetic testing for patients that we suspect to have a cardiomyopathy or channelopathy. So if genomic medicine is now officially 16 years old, any of you have 16-year-olds, you know we're dealing with, in part, a raging out of control adolescent with a mind of its own. And we need to learn how to harness the energy of this adolescent, because if we don't, and if we don't discipline it, or him or her, we will have a mess on our hands. And analogous to raising a teenager, we're in that exact same state, I'm afraid, when it comes to genetic testing. So to not be like that and to be in control, you and I need to competently and confidently know the answers to these 3 questions that we'll go through. First, do you and I know what is that genetics test impact across the triad of medicine? We need to know that. Second, do we know what is the yield of that genetic test when I think that that patient has disease A, B, or C? And then third, and most importantly, we need to understand what is the genetic test's dark side? What is its Achilles heel? Well, to underscore and to make it clear that the impact of genetic testing is irrefutable, I'd like to start with a family that I've had the privilege of caring for. This could be one of many, many families, and this isn't their photo. I just lifted this from Good Housekeeping. But this representative of a family that I take care of, where for many families, as you know, where the endpoint is tragic sudden death, it often starts with the tragedy. And indeed it did for this family, where their oldest child, Chase, died suddenly at the age of 8 in Sunday school, of all places. And this is the reason for Chase's sudden death. You and I would quickly be able to tell us this is her heart, and you would say she died, yes, at age 8, a sentinel event from hypertrophic cardiomyopathy. So those people who take care of people with hypertrophic cardiomyopathy, who say it doesn't strike before adolescence, you know why they say that? Because they're not an adolescent physician. HCM does and can declare at a young age, and indeed it did. For this family, they would then get the most important next test. You know what that test is? We're talking about the state of genetic testing? No, it's not a genetic test. They got the functional genomics test, otherwise known as an echocardiogram. So for those of us who are genetic cardiologists, that's what an echo is. It's a functional genomics assay. How do you like that, the echocardiologists in the room? So, and they did, and with that, it would reveal a classic autosomal dominant pedigree of hypertrophic cardiomyopathy, where the father had non-obstructive HCM, asymptomatic his entire 40 years, triple athlete, university level until discovered by echo. Baby brother had an 18 millimeter wall thickness at 18 months of age. And so that family and that child would be rescued at age 2 with his automatic defibrillator by the mother after he got out of the bathtub and was toddling down the hallway. And unfortunately, on episode number 13, after he got an ICD, 12 VF terminating ICD shocks from age 2 to 6, and tragically, episode number 13 was tragic. And now the family is cut in half, and they now come to us as a genetic cardiologist with a fundamental question. What's the cause? And how sure are you that our 2 living children whose echoes are normal don't have it being the disease-causative mutation? And here would be the answer. Out of 3 billion nucleotides of genetic information, what we're suggesting is that's the problem right there. That is the fundamental root cause, and that would enable us to do what the guidelines would call for some 9 years later: cascade testing, family-specific, mutation-specific testing to identify the haves and the have-nots. And you can see the power of the genetic test result, can't you? Her echo is normal for a good reason. Not only is she prepubertal, but she's negative because she's negative. She doesn't have it. She doesn't need to be followed for it. She can't pass it on. On the other hand, he is positive. He would be now called what? A prehypertroph, or somebody who is genotype positive but phenotype negative. And I don't want to focus on the end of his story, alive and well, but just as an aside, anybody want to hazard a guess what the mother insisted we do for her mutation positive echo normal 10-year-old? A prophylactic ICD, for which we said, we don't do that. Well, the score over the last 12 years has been ICD shocks 5, with his first shock occurring while his echo was still normal. Now, that's not to get off on a rabbit trail of that issue. What it is to show is unequivocally the power of the genetic test result, where we followed the daughter in a dramatically different way than we followed the son. That's what the genetic test can do at its best, to provide the power of closure and clarity. And it does so for the cardiomyopathies, for which I love all of these phenotypic flavors of the cardiomyopathies, but I want to make some points in particular with the most common at a young age. Of course, DCM is more common at older age. Where these are this is the genetic landscape of the HCM susceptibility genes, where these are the major ones that encode the critical elements of the cardiac sarcomere, which gives rise to the HCM category of sarcomeric HCM or myofilament HCM. And then these are These are the genes that encode the adjacent scaffolding proteins of the Z disc that gives the subset of HCM genetically that we call Z disc HCM or cytoskeletal HCM. But like that famous Ginsu knife commercial, you remember that one? But wait, there's more. And that's true in genetic testing. There's more, and these are These are the so-called HCM phenocopies or metabolic mimickers of HCM, Fabry's disease, Dannon's disease, and so forth. And we round it out with those genes that encode the calcium mishandling proteins. And so you can have calcium handling HCM, or when it's perturbed, calcium mishandling HCM. This is quite a waterfront of HCM susceptibility genes, when depending on how you count, there's at least 25 of them. We could reduce it, but we're in an era of why make the genetic test panel smaller when you can have it all? And we'll probably come back to that, because one of the best things we could be doing in genetic testing in the future is shrinking the genetic tests. But nobody's going to do that, because everybody is in the genetic test panel arms race. You know, my panel is bigger than your panel. And we have a problem because of that. In fact, let's skip the panel testing and let's go to what? Whole exome testing. You can have it all. And when you have it all, you sometimes get it all, and we'll talk about that. But these are the major ones. In fact, you could probably purify the HCM genetic test and distill it down to 2. At 12 o'clock, myosin binding protein C HCM, and at 1 o'clock, MYH7 or beta myosin heavy chain HCM. And you could almost forget about the rest. I'll ask you what the yield is in just a second, but does it matter? Does it matter to know that your patient is sarcomeric HCM? I mean, your patient. Not what I showed you for the daughter and the son for cascade testing, but do I, as an HCM specialist, want to know, does my patient have sarcomeric HCM, genetic test positive HCM, or is there HCM due to or stemming from a negative genetic test? I don't know if you want to know. I want to know, and I want to know a lot, because those HCM individuals are different. Those who have a positive genetic test, they are fundamentally a different HCMer than those who have a negative one. They're younger statically, they're younger at presentation, they're thicker, there's more apt to be a family history of disease, and they were more apt to have had us implant a defibrillator. That's at a static point in time. And then dynamically, we showed over a decade ago, and it's now been shown again and again, that compared to those with a negative genetic test, those with a positive genetic test do worse. They are more likely to progress to important endpoints. So I want to know what kind of HCM patient I have in front of me, even when I'm not wrestling with their clinical diagnosis of HCM. The guidelines agreed as well, given the impact across the triad. The guidelines make it really clear. If you and I are taking care of a patient with HCM, we should be doing HCM genetic testing for the patient and for the benefit of that patient's family as Class 1 and Class 2 recommendations. And we reiterated this and emphasized this last year in the ventricular arrhythmia guidelines as well. If we look at the channelopathies and the impact across the triad of medicine to know that answer, I love the channelopathies. Isn't that an incredible subdiscipline in the heart rhythm world? The most common being long QT syndrome. It affects about 1 in 2,000 individuals. HCM, about 1 in 500 individuals. Long QT is quite intriguing because they may or may not even show a long QT interval. They may or may not ever have a torsadogenic experience. In fact, the majority of the 1,300 plus patients with long QT syndrome that I take care of, the majority are waiting for their first event. Most long QT syndrome resides in an asymptomatic state. We've come a long way. We've now passed the 60th anniversary since the sentinel description of this disease. The birth of this entire discipline of the cardiac channelopathies this last month is 24 years old, when Mark Keating in Salt Lake City discovered the root cause by showing the world the problem in long QT syndrome stems from defective ion channels in the heart, like loss of function mutations in this voltage-gated potassium channel. That discovery in 1995, which I personally think Mark Keating deserves a Nobel Prize for, ushered in the era of research-based genetic testing. How many of you practiced in that era, 95 to 2004? Remember, that paper's coming left and right about the power of the genotype. Genotype-phenotype correlations coming out of the Arthur Moss-led International Long QT Registry with Peter Schwartz. All of this momentum and energy, and guess what clinicians thought about this decade? They didn't like it. We referred to it as the black hole, the time and place where samples went and nothing came back. And then ultimately it gave way, it matured to clinically available genetic testing in 2004. New problem, available to us, denied. And then 10 years ago, there was progress made with the insurance landscape improving, where genetic testing for cardiac diseases like ours, with long QT syndrome being the front runner, was declared a clinical test and no longer an investigational test. That was an important milestone in 2008, but now a new problem. Increasingly available to us, the cardiologists, increasingly reimbursed by the third-party payer landscape, and now increasingly being utilized by clueless users. And that is a bit of the world where we find ourselves right now, is we are not so good at using the test wisely and in interpreting the test results correctly. And we've had guidance now as of 8 years ago on how to use genetic testing for long QT syndrome, for we're now up to 17 long QT syndrome susceptibility genes. And even though our lab has discovered most of the minor long QT genes, they don't matter. The ones that matter remain the ones that Mark Keating discovered 24 years ago. 20% of long QT syndrome, when I know long QT syndrome is the correct diagnosis, 20% will be genetically elusive in 2019. But these are the ones that clinically matter the most. We're excited about the calmodulopathies. We're excited about triad and knockout syndrome, but their relative contribution to long QT syndrome is un poquito. These are the major long QT genes that account for about 75% of the entire syndrome. And we know a lot about LQT 1, 2, and 3. We know about the triggers. We know about what upsets LQT1 compared to LQT2. We know that postpartum is a vulnerable window of time in LQT2 women, but almost never LQT1 women. We know that if a long QT person goes down while swimming, it's almost for sure LQT1 and not the other genetic subtypes. And we know that there is genotype-specific responsivity to therapy. We don't have very many genetic heart diseases where the genetic test result clearly guides and directs clinical management. We do in long QT syndrome, and we do in the aortopathies, where we ask a surgeon to come in 5 millimeters sooner for certain kind of aortopathies over others. And we do that in long QT syndrome, where beta blocker have differential effectivity and efficacy on the long QT genotypes. And we are even doing, and have been doing for quite some time, what's called intragenic risk stratification, where here in the LQT2 potassium channel, mutations from stem to stern, they don't all behave the same. In fact, those patients who have poor localizing LQT2 mutations, they do more poorly. You like that one, Dr. Elder? That was for you. I did that just for you. So we're doing intragenic risk stratification. So if you said to yourself, I'm taking care of a patient with long QT1, I would say that's so yesterday. You should be asking yourself, what kind of LQT1 patient are we taking care of? Haploinsufficient, dominant negative, C-terminal, poor localizing. We are doing intragenic risk stratification and now increasingly doing even mutation-specific risk stratification. So with the impact across its triad, the guidelines are really, really clear. If we're going to take care of a patient with long QT syndrome, if we think we're going to call him or her long QT syndrome, genetic testing is a class 1 indication. So the answer to the first question, what is the impact across the triad, you should leave here saying, it depends. It depends on what disease are we talking about, because it's not a one-size-fits-all. It depends on the genetic heart disease that we're dealing with. And we talked about for HCM the impact and for long QT. The point is, we need to know what that impact is. And it may be different for the different cardiomyopathies and channelopathies. So I don't want this cardiologist to be using genetic testing. Who is this cardiologist? He, she asks this question often. They say something like this: will you screen my patient to see if he or she has one of those bad thingamabobs, or whatchamacallits, which we now know to say disease-associated mutation, and actually we need to be better than that, because strike mutation is an offensive word. We're now supposed to say disease-associated variant. So, but do they have a pathogenic variant? So I know whether or not to implant an ICD. That cardiologist who asked that question is dangerous. And we have too many cardiologists asking the question in that way. And the reason why they're dangerous is that the presence of that, the disease-causative pathogenic variant, should almost by itself never result in that an implantable defibrillator. So we need to know what the test will do for us, what its impact will be across the triad, so we can take care of the patients as well as we can. We really have to know the answer to that first question. Now we have to also know the answer to the second question. What is the genetics test yield? In other words, what's the likelihood that that test will come back positive? The person who should be least surprised by a negative genetic test is us. So we should know how much of our disease that we think our patient might have is accounted for by a Mendelian genetic cause. we shouldn't be surprised with a negative test. So let's look at the cardiomyopathies, and I'll have you help me. You're going to vote, and you don't even get a vote anonymously. How's that? So you have a patient where you are rock solid on your clinical diagnosis of hypertrophic cardiomyopathy. You're not wrestling with athlete heart versus HCM. You're going to call this patient HCM. What's the yield of the HCM genetic test for your patient that you have clinically diagnosed with HCM, are treating for HCM? How many say the yield, the likelihood that the test will come back positive, is 10%? Okay, 25%. 1, 2, who will give me 55? No, 50%. Okay, so we're at halves. 75% will come back positive. A few, 100%. It will always come back positive. So no always. So we have a bell shape at 25, 50, 75. Guess what's the beauty of that? You're all right. Or we're all wrong. And this is where I think this will be really helpful. If you said 50%, that's a good guess. That's a reasonable guess if you know nothing about your HCM patient who you're encountering. And you're just told HCM next room, okay, 50% chance. If it's ARVC, we're at about a 50% chance. If it's DCM, we can unpack this a little bit, but it was 20% just a few years ago, and it's risen. But let's come back to HCM. I want you and I to be better at what the yield of the genetic test would be, because it's not 50%. We did genetic testing on over 1,000 consecutive patients, all diagnosed with HCM by our HCMologists at Mayo Clinic. You might have heard of some of them. Rick Nishimura, I think he knows HCM. Steve Amman, I think he knows HCM. Bernie Gersh, just ask, he knows HCM. So these people know HCM, and the yield of the genetic test among them was 38%. So if you leave saying the yield of HCM per Mayo Clinic is 40%, that would be a better number than the 50-50, but guess what? That's wrong. What are we getting at? What I'm trying to get at is underneath the hood of HCM are a lot of different diseases. And we can refine the estimate by just knowing a couple things about our patient. Are we talking about this kind of hypertrophic cardiomyopathy, so-called sigmoidal shaped, where about half of all of our patients that we see have this version of HCM? Or are we talking about this kind of HCM, so-called reverse curve hypertrophic cardiomyopathy, where about 1/3 of our patients have it? Does the shape matter? You bet it does. In fact, it matters the most, because if we order the HCM mutation spell checker for the HCM on the left, guess what? It almost never comes back positive. If we order that exact same HCM genetic test for the HCM on the right, it usually comes back positive. And then this has allowed us to do what we call at Mayo echo-guided genetic testing. In that the echo, the phenotype by echo or by cardiac MRI, guides our pre-test anticipation of whether we're dealing with sarcomeric HCM or not. And then what we can expand besides echo-guided genetic testing, for which as we brought that into practice, it's still, the echo morphology is still the single strongest determinant of whether our genetic test will come back positive or not. But we can do better than that. Look at this. Just knowing, can I count to 5 and even subtract 1? If we know 5 things about our patients, we can then tell you that the yield of the genetic test is going to be as low as 5% or as high as 80%, even though all of them are called hypertrophic cardiomyopathy. In other words, are we dealing with this kind of HCMer? Who is he? He was diagnosed at age 25. His wall thickness is 22 millimeters. We elicited family history of disease and death, and by echo, the shape is that reverse curve, and blood pressure is perfect. That hypertroph has an 80% likelihood of a positive genetic test result. Or are you taking care of she? Who is she? She's that 65-year-old diagnosed at 63 with obstructive HCM, has that basal bulge. And you and I asked about family history as many ways that we knew how to do. and it's called negative. And the blood pressure is 145 systolic. We called her hypertrophic cardiomyopathy. We might have even had Joe Deraney or Hartzell Schaff, our myectomy surgeon, do a septomyectomy to relieve her left ventricular outflow tract obstruction for her symptomatic HCM. But she will almost for sure have a negative genetic test. Probably not a familial disease at all. That has implications not for your patient, but for Dr. Elder and the colleagues to say, now what do I do with her grandchildren? We're talking about a different form of HCM. And when we understand what we'll come to last, which is the noise in the system, you can see that by knowing the phenotype and by knowing the yield, you and I become better at signal to noise adjudication. Because then her test likely to be positive, and guess what? A true positive. Her test almost for sure won't come back positive, and when you think it does, think again. It's probably a false positive. So that's how we can be better with the genetic test. And the yields aren't static. They can change, can't they? This is what we would quote as the yield of genetic testing for DCM just a handful of years ago, until this work that we contributed to from Cricket-Seidman doubled the yield overnight with titin-mediated dilated cardiomyopathy. So the single greatest contributor of non-ischemic DCM are loss of function mutations in titin, which has doubled the yield. Some might say it's also doubled the problem, and we'll come to that shortly. What about the yield in the channelopathies? You know your patient has long QT. You're not wrestling with that diagnosis. 80% of long QT is genetically accounted for. Brugada syndrome is lower. CPVT, about 2/3. Brugada is 10 to 40%. Why is it 10 or 40? Simple. If the PR interval is normal, it's less than 10%. If the PR interval is prolonged, it's 40%. That's a little bonus. Short QT syndrome, who cares? So we won't focus on that. Long QT at 80%, here's what I'd like you to take away with that piece of information. Is something that I call, what's your batting average? I think anytime you and I order the long QT genetic test, we should say to ourselves, my clinical diagnosis is rock solid definite. It's possible. It's no. In fact, I don't think this person has long QT, and I'm expecting a negative genetic test to help move away from the diagnosis. And when you're thinking that, follow your batting average. It will make you a better diagnostician because it will sharpen your phenotype sword. So for example, I have a colleague who he has told me, and he is bragging, that his batting average is 80%. He says, Gene Company X has whispered in my ear that of all the tests that I've submitted, I'm getting a positive answer back 80% of the time, and that I'm the best in the industry. And I shake my head at him, and it's a him, and I say, don't brag. You're using the test poorly. Because to be at 80%, you are underutilizing the test, because the only cases that you could be submitting for long QT genetic testing to have 80% is, I don't know, maybe how about the patient who was swimming and then they sank, and then their loop recorder recorded torsades while they were sinking, and then upon surfacing their QTC is 550. That's how you get a batting average at 80%, because most of us know that long QT patients don't always come as obvious as that. And then on the other side, there's a colleague, I use that term loosely, who is in a bit of a slump. And it's a he, and he has ordered the long QT genetic test over and over and over again. And guess what? He's waiting for that first magical moment called, it came back positive. So he is either an early adopter to universal genetic testing, that's how you could be in a slump, or he doesn't have the foggiest clue what constitutes the phenotype to warrant a diagnosis of long QT syndrome. And by keeping track of your average and what your average should be depends on what's the phenotype. My average for every long QT genetic test that I've ordered is 40%. When I have said you absolutely have long QT, it's 80%. When I've said you absolutely don't, I'm on a hot streak, it's still running at 0. And when I said it's possible, Schwartz score 3-ish, for those of you who are aware of that, it's running at about 40%. It can help you be a better diagnostician, because if you're saying definite long QT, definite long QT, definite long QT, and your yield is 50%, you need to recalibrate what your definition of definite is. And that has really helped hold me true to reassessing, why was I so sure it was going to be positive and yet it's negative? Yeah, it could be negative, 20% is, or did I miss something? Did I overbite on a U wave or something? Did I subscribe a rhythmic syncope to that spell when maybe it wasn't so arrhythmic as I anticipated? For sure on the left, you have a dull sword, and I don't want you to have a dull sword. So one of the ways, I don't know what the wiring is among cardiologists and how many sharks are in the water here, but are you curious who that person is? Because I'm ready to expose him. I'm just kidding. I'm not going to do that. But it does remind us that even as we talk about genetic testing, we have a tremendous need for these rare diseases for us to be better phenotypers. In the heart rhythm world, where the sweet spot in adults is AFib, and in peds heart rhythm, it's WPW, for example, we're not great at phenotyping the genetic heart rhythm diseases. We need to do better in our own home. Phenotype is king. It is the most important. And so there's a story behind that, but I'm not going to give you that right now. An important point of emphasis, if you're not certain about the phenotype, don't go fishing for the genotype as, oh, I'm not sure what's going on, but let's do the genetic test. It will clarify everything. What's the test yield? And to round out our 10-minute of monologue before our conversation gets to begin, do you know the answer to the third and most important question, which is, what is the test noise? I don't know about you, but when I think of the master physicians at our institution and your master physicians at yours, one of the things that I think describes him and her is they really, really know the weaknesses in the test that they're ordering. They know what the test, whether that test is an ECG, an echo, an MRI, whatever it is, a biomarker, an LDL cholesterol. They know what is the strength in the test, but they really know what is the noise in the test. And we have to be signal to noise minded when it comes to genetic testing as well. And what is that signal to noise mindedness? It is the answer to this question. Is the X that marks the spot truly the disease-causative mutation or variant? Because for the power of the genetic test in terms of closure and clarity to work, we better be right when we're saying we found it, and now we're going to use it to dismiss because you don't have it, to watch closely because you do have it, or to refine our therapies because you have LQT1 instead of LQT3. We better be really right about it. And in fact, the guidelines even say that ongoing screening is not indicated in genotype negative individuals. In other words, those in the family who have a negative test result. Well, we better be really sure that the positive test result that we're using to track is really the positive result. And this not so clear. And we have been fumbling over and over again for the past 16 years since genomic medicine was ushered in on understanding how sure are we that X marks the spot. And we haven't listened very well to this incredible philosopher who said with great power comes great responsibility. For a long time, until recently, if you were to ask the question, what's the background rate of ultra-rare genetic variation in our genetic code? People would say, what are you talking about? And that answer, that insight was provided for our diseases a long time ago, long before Exact, long before Nomad, the Genome Association database. And we were able to show what is the noise in the system. Now, people react to this background noise issue and say, what are you talking about? I'm not quite sure what you're talking about. And we refer to how many of you are aware of VUSs? Variants of uncertain significance. We act as if this is a brand new issue. This is like so old because we warned of this circa 2003. That's really interesting, isn't it? Remember 2003? $2.7 billion, inward voyage of discovery, greatest feat of exploration, completion of the Human Genome Project. That same year, we sounded the alarm saying, be careful. There's noise in our genetic code. There's noise in irrefutable disease-causative genes. And we backed it up the following year saying, warning, there's noise in the sodium channel as well. And that noise, that warning, guess what? It was completely smothered and silenced because we weren't ready to hear that message because we were too busy with the cheerleading pom-pom doing the rah-rah on the Human Genome Project. And we, in fact, got scolded when we did this reverse experiment. We were in a public meeting presenting disease-causative variants scattered throughout the LQT1, 2, and 3 ion channels, and we announced the reverse experiment where we then sequenced normals. And we were asked, why are you spending money sequencing normal individuals for irrefutable sudden death associated long QT genes? And we said, because. What if there is noise? There won't be noise there. Because these are irrefutable disease susceptibility genes, so of course we can't put noise in the system. And we said, who says that? Let's find out, and that's what we found, just in the big three. And we said there's fascinating structure function to be get because the noise isn't random. The noise localizes to territories of the ion channels that have biological flexibility or tolerance, where they'll tolerate change. There's other portions of the channel that are intolerant of amino acid substitution. And in 2003, we said exercise extreme caution when calling mutations. Extreme caution. Just look at the sodium channel. Is the sodium channel encoded by SCN5A an irrefutable LQT3 disease gene? Absolutely. No doubt. These are the putative LQT3 causative mutations. Is the sodium channel loss of function mutations in it responsible for Brugada syndrome? Yes, no doubt. These are we think. Is there noise in the sodium channel? No doubt. These are Rare genetic variants is found in 1 of 1,000 blood donor, 1 of 1,000 blood donor, 1 of 1,000 blood donor. 2% of us in this room have something really rare in our sodium channel, such that if you and I offered an ECG suspicious of LQT3, we would say case closed, slam dunk, you have LQT3. But if you're looking really, really, really normal, and we just so happen to have gotten genetic testing done on you as an Odyssey case for your intellectual delay or your chronic recurrent abdominal pain, otherwise known as CRAP, and then you get an SCN5A variant, we should be careful from telling our patients, I have not been able to explain your CRAP, but you have Brugada syndrome. And that's what's happening right now in the genetic Odyssey land. And we need to be really careful. These things are there. And how would you like to interpret the variance in that rectangle? Not likely to be it at all. There is much to learn about real estate. Location of the variant matters. Not all locations have the equal prior probability of being the disease-causing mutation. In other words, these genetic test results are fundamentally probabilistic in nature. Well, that's just the ion channel genes. There would be no way that we would put noise into more important genes, meaning the genes that encode structure elements, the cardiomyopathy susceptibility genes. That was the saying after they reluctantly accepted this data 15 years ago. Sorry. Yep, it's in them as well. Your HCM genes, noise is there. DCM genes, the noise is there. ARVC genes, the noise is there. There is noise in the system. And in fact, as the panels are getting bigger and we're having more and more genes on the panel, if we just did the major disease genes and we ran the panel of the major HCM, major long QT, major CPVT genes, and we ran that as a panel, guess how many of us would have something really rare in one of those? 13.5% of us. If we ran the entire panel of all 100 known implicated sudden death genes, how many of us would have something really rare? 44% in the entire panel. In just the big 4 channelopathy genes, 7% of us have something really rare. There's noise in the system, and we call that noise in the system, and I've called it genetic purgatory. And you need to know about genetic purgatory. You need to believe in genetic purgatory because it's a real place and it's a scary place. And those who respect it the most will do the best at navigating through the noise issue. Well, we're at 10:02 and I was asked to preserve 10 minutes for some conversation. So let me take you to the take-home points. We illustrated in the cardiomyopathies, mostly HCM. We can talk about the others if you want. We're now at 25 genes and counting. I hope you leave with a newer understanding of how to anticipate the yield based upon phenotype. So phenotype-guided genetic testing, where the yield for HCM will now range when you leave today from a 5% estimation to an 80% based upon shape, largely, and then age, family history. But shape is the strongest determinant of whether that HCM genetic test will come back positive. In the channelopathies, we spent most of our time on long QT syndrome, for which there are now 17 genes and counting, but really it's back to LQT 1, 2, and 3 as the 3 canonical genes for which the yield is 80%. And I tried to illustrate the concept of knowing your batting average so you can compare what you thought with what the genetic test yield is to see, do you need to sharpen your phenotype sword at all? Is it getting a little bit dull? And then we concluded with an emphasis on making sure, just like virtually every test that we do in cardiology, I mean, we of all people, cardiologists, should be really, really good with probabilistic tests. That's called like almost all of our tests. So we've had this, I would say, genetic exceptionalism, or whatever we want to call it, where we've expected genetics not to be probabilistic. We've anticipated that it should be, ought be binary. Yes, no, give me the answer. And it's not. These tests are probabilistic tests. X does not always mark the spot. On the other hand, a VUS might be a variant of uncertain significance by the genetic test company. But in a nanosecond, I can promote that VUS to an irrefutable disease-causing variant. They can't, I can. Why? Because we are the phenotypers. And we have the power of the phenotype to weigh that variant's veracity in the balance. But X does not always mark the spot. And I hope you will embrace, not be afraid of, but believe in the existence of genetic purgatory. Because those who do have the possibility of being a wise user of genetic tests, which we need to become much wiser, and an even wiser interpreter of those genetic test results so that we can make wise decisions for these amazing families that you and I have the privilege of caring for in our practices. And with that, I'd like to give you a selfish invitation. If you're intrigued about genetic heart disease and you know that your genetic IQ is not where you want it to be practicing in this space, to come to our 4th genetic heart disease course. You're going to like it a lot. It's at a neat place. And join us in October in about 6 months. And with that, I'd just like to recognize those programs and entities that have partnered with our program, in particular the philanthropic support from Wendy's family. And I would love to entertain any questions and conversation that we can have together. Thanks.